There we go. Can we see that PowerPoint?
Yep, that's perfect.
Okay, wonderful. So let's go back here. We'll start back over. Okay. So hey guys, welcome to the St. E continuing education for EMS. This month we're going to be talking about pediatric trauma. So just a little bit about myself, just to give you like a quick background. I've been a registered nurse since 2020. Started in the NICU at Miami Valley and transitioned down to the NICU at Cincinnati Children's. I've been in the emergency department at Cincy Children's for the last 3 years. And then I also recently got my paramedic license, and I currently work as a flight nurse through Air Evac. So just a little information about peds trauma. So pediatric trauma is the leading cause of morbidity and mortality among children worldwide. And in the US alone, trauma accounts for over 16,000 deaths annually in children under the age of 18. This makes it the _1 leading cause of death in this age group. Approximately 20% of all pediatric emergency department visits are actually due to trauma-related injuries. Globally, unintentional injuries such as falls, MVCs, drownings, make up the leading cause of pediatric trauma. Going back to 2019, road traffic injuries were actually the leading cause of death for kids ages 5 to 14, which accounted for roughly 40% of all unintentional injury deaths in this age group. So when we think about pediatric trauma, we have to remember like the economic burden of the pediatric trauma is so substantial, specifically with direct medical costs and long-term care needs, resulting in a significant financial strain for these families and healthcare systems. Despite all of the injury prevention efforts and treatment, there's still a high prevalence of pediatric trauma, and the need for ongoing efforts in public health, education, and policy to reduce the incidence and impact of these injuries. So kind of just going back, even though pediatric trauma is high, and it's the leading cause of death and mortality in this age category, in the past 2 decades, for ages children 1 to 14, it has declined significantly, but still remains a leading cause of death. Let's see. So just a little bit of background. I think we're all pretty aware and agree that EMS providers tend to often lack information, training, and confidence when it comes to pediatric patients. This is primarily due to low call volume. Just some statistics here. So kids make up roughly about 10% of all EMS calls, and critically ill or injured, specific like pediatric blunt trauma and things like that, are an even smaller fraction. Because EMS providers rarely encounter these cases, clinical exposure and skill retention and pediatric assessment and interventions are usually limited. The use it or lose it is real, guys. So we need to be practicing skills for pediatric patients, such as airway management, or using our Braslo tape to figure out weight-based dosing, because this can quickly fade without using it on a daily basis. There's also a pretty big training gap in EMS education, specifically going through medic programs. Many EMS programs spend a minimal amount of time on pediatrics compared to adult care. Sometimes roughly EMS programs can only take a few hours or maybe just a single day in the entire curriculum to go over pediatric patients. Pediatric sims, scenarios, and hospital rotations are often optional or very inconsistent, sometimes with the inability to do hands-on care in the hospital setting. And some programs rely heavily just on lecture-based training with little opportunity of hands-on education. And then we also have like some systemic and resource challenges as well. Pediatric equipment isn't always stocked or organized or easily accessible in ambulances, especially in rural systems. You find that whenever you go to a rural EMS, it is extremely difficult for those EMS providers to provide adequate care to pediatric patients, because it's a low frequency, but it's a high fidelity type of patient. And then we also can couple in there some like provider anxiety. Pediatric patients, especially neonates and infants, can trigger high stress and uncertainty due to size differences, communication barriers, and emotional involvement, especially those providers who have children. EMS providers often rely or report feeling less confident in assessing and treating kids, even when they may know what to do. The lack of confidence can slow down care, can increase hesitation, or lead to over-reliance on adult-based protocols. There's also a gap between pre-hospital and pediatric hospital systems. Pediatric hospitals tend to have specialized staff, but EMS doesn't always have structured collaboration or feedback loops with them. So that makes it a little bit difficult. And EMS doesn't always have learning outcomes from pediatric transports or continuing education to bridge these gaps. So that's important whenever you're going into the hospital to get your CSN, follow up with your patients following a transport, especially of a critical pediatric patient. And then programs like EMS for Children, it's an initiative, and pediatric readiness projects are trying to work to bridge the gap. But pediatric simulation labs, mobile training units, and partnerships with children's hospitals and EMS tend to be improving for education. Another way that you guys can do this is work on pediatric simulations back at your department. So just overall, EMS tends to lack pediatric training and information, not because of neglect, but rather like rare exposure, limited curriculum time, and inconsistent support systems. And even highly skilled medics can feel uneasy treating kids. Moving on. So in the lesson, we're going to focus on like what is trauma, differences between adult and pediatric patients, assessment of pediatric patients, and common mechanisms of injury in kids. So what is trauma? We're starting off with physical trauma. Let's go back. So physical trauma refers to any injury or damage that occurs to the body as a result of an external force or violence. It can range from minor cuts and bruises to more severe injuries like broken bones or internal bleeding. Physical trauma not only affects the body, but it can also have a profound effect on one's emotional and psychological well-being, whether this be caused by accidents, sports injuries, acts of violence, physical trauma. It's a reminder of the vulnerability and resilience of the human body. So who is a trauma patient? A trauma patient is a person who has suffered a physical injury, or which may be minor, serious, life-threatening, or potentially life-threatening. Trauma injuries are often categorized as blunt or penetrating, and there are also different levels of physical trauma. So the severity of the trauma is classified according to the injury type, physical location, injury, and how many injuries there are. If a person has many or what we would consider multi-trauma or severe injuries, this would be classified as we all know, a major trauma. And then some major and multi-trauma patients can experience some pretty significant complications, which includes hemorrhage, infection loss or sepsis, or multi-organ failure. Then moving down to, do all hospitals treat trauma patients? I'm sure that we're all aware that there are 2 level 1 trauma centers in the Northern Kentucky, Cincinnati area. Pediatric only, there is one, which is Cincinnati Children's. And then just a quick overview of like the differences between like level 1, level 2, and level 3 trauma centers. It all comes down to like comprehensive care centers. Are these places capable of caring for a multi-system trauma patient? And then it comes down to doc coverage. So Children's, being a level 1 trauma center, they have to have 24-hour in-house coverage by general surgeons and specialists, including ortho, neuro, and anesthesiology. Level 2 is more similar to level 1, but the difference between level 1 and level 2 is the research capabilities. So oftentimes whenever you take a patient to Children's or you see docs, residents, fellows, you can see clinical trial specialist in there trying to get information from you guys if you bring in a specific patient population that is close to one of their clinical trials that they're offering. And then level 3 is basically like an initial evaluation, stabilization, and then a transfer out to these level 1 trauma centers. This is just a quick map of the level 1 through 5 trauma centers in Kentucky. So our level 1 centers are going to be in Louisville and Lexington, U of L and UK. And then the closest trauma certified center would be a level 4 in Harrison County at Harrison County Memorial. And then moving to Ohio, so your red dots are your level ones, green dots are level twos, blues are level threes. So the closest to you would again be the University of Cincinnati for adults and for peds, Cincinnati Children's. Okay, so here's just a quick overview of the classification of pediatric patients. This is going to be important to remember later when we discuss burn patients and different burn percentages. But neonates are anywhere from birth to a month. Infants are 1 month to 12 months. Toddlers start from 1 to 3. Then we move into preschool age 3 to 6. School age is 6 to 12, and adolescent is 12 to 18. So I know a lot of us have heard the saying that children are little adults. It is so, so important. If there's one thing that you guys take away from this, please take away that children are not little adults. Their bodies are totally different. Their metabolisms work in different ways. Their body structures are very different than adults. So it's really important to brush up on our pediatric information to know that children are not just little adults. So here's a little infographic in regards to why children are not little adults. They have anatomy, their physiology, and responses to illness and injury are basically completely different than adults. These differences affect your assessment, your treatment, medication dosages, and even communication with your partner, the patient, and with the family. So starting off with anatomical differences. So pediatric patients are particularly susceptible to trauma just due to their distinct anatomy and physiological characteristics that differ from adults. Their bodies are still developing, which makes them more vulnerable to injuries for a variety of different reasons. They have proportionately larger heads. Their heads are just significantly bigger than the rest of the body, which makes them more prone to head injuries, especially during falls or impacts during an NVC. And then their increased head to body ratio also shifts their center of gravity. So they're top heavy, which makes them more of an increased risk of falling. They have less mature bones. So as we know, pediatric bones are softer and more pliable, which makes them more susceptible to bend or buckle fractures for falls rather than a clean break. These types of injuries can also affect the growth plate and can affect future bone development as opposed to adult patients where their bones are fully developed and our growth plates are closed, so we don't have to worry about those types of injuries. They have smaller airways and more flexible chest walls. So we have to remember this whenever we're intubating these patients. Their airway is narrower and more easily obstructed, which can lead to respiratory complications during trauma. And additionally, their chest wall is more compliant, which means it's more pliable, which makes the severity of internal injuries more significant, especially to the lungs during blood trauma. They have higher surface to body mass ratio. So they have a higher surface area relative to their body mass, which makes them more susceptible to hypothermia. So our good old trauma strip and flip, we have to remember that we need to put them back covered, whether that be with a warmed blanket, whether that be with a trauma blanket, sheets, whatever we have, we need to make sure that we are replacing the heat source so that way they don't become hypothermic. They also have smaller blood volumes, which means that they can experience significant blood loss more rapidly than adults, which leads to shock more, faster than you would see in an adult patient. They also have immature psychological responses, such as cardiovascular and thermoregulatory mechanisms, which can make them less able to adapt and compensate for their injuries. So they might be able to maintain a normal blood pressure when a significant amount of blood loss has occurred. But like we are always taught, we get to the edge and then we fall off. And that's when we have some real significant issues. So these differences make these patients more vulnerable for immediate and long-term effects of trauma, meaning that these kids are likely going to need more specialized care and managements for their unique needs. Physiological differences. So children are able to compensate for shock by increasing their heart rate, but not by increasing their blood pressure. So if you're seeing a pediatric patient that is tachycardic to tachypneic, their blood pressure is going to be the last thing to change. So if we're noticing these subtle changes, we can intervene more quickly as opposed to waiting until we see a drastic change in their blood pressure and then potentially maybe it being too late. So hypotension, like I said, it's a late and ominous sign. And by the time that you see it, these patients are in decompensated shock. Um, Kids also have a higher use of oxygen and metabolism, which means that they can deteriorate faster when hypoxic or are not breathing effectively. This is why ventilation is often more critical than compressions in pediatric patients. This takes us back to remembering that pediatric patients are likely to arrest due to respiratory rather than cardiac. And then again, their total blood volume is smaller than an adult patient. Medication and dosaging, these pediatric patients, they're weight-based dosages and they're not standardized like our adult-like protocols. And we have to remember that a milligram too much or a milligram too little can make a huge difference in these pediatric patients. So make sure that we're using our Braslow tape or reference guides to negate any medication errors. And then again, with metabolism and medication, we have to remember that drug metabolism varies with age. So neonates, infants, and other children often process medications differently. So just something to keep in mind and remember. And then number four, developmental and communication differences. Children can't always describe or localize where they're feeling pain. And our assessment, a very good quality assessment, relies heavily on observation and caregiver input. So in these pediatric trauma patients, if we have the availability of parents or family, it's super important to utilize those resources because they are going to be the best source of information because a parent knows their child best. We are getting a brief 30-minute assessment and eyes on this patient, and we don't know what this patient's normals are, how they typically act. So utilizing family, parents, siblings, if they're old enough, are extremely important. And then fear and anxiety actually play a huge role in pediatric patients. So, kids may cry, they may hide, they may become uncooperative. That's when it's also important to utilize our family and siblings as well, changing the way that we're communicating with these patients. And we'll discuss communication to pediatric patients later in this PowerPoint, but just something to remember. And then five, psychological and family dynamics. A sick or injured child may mean multiple patients. So you have the patient and the family. And a parent's distress on scene can sometimes lead to misjudgment, scene control, and decision making. We might see a parent in distress and we're like, our stress level is heightened because now not only are we trying to care for this traumatic injured pediatric patient, but we're also trying to deal with the family as well and keep them calm and cooperative. So you might have to, if you have extra staff on scene, balance the critical care aspect of your providers, as well as family assurance and emotional management of your extra providers to talk and kind of just go through what you're doing, where your mindset is going, and what you're doing with that pediatric patient so the family understands. And then six, just operational and system differences. Equipment size, like we know, varies. Children often need to go to a pediatric capable hospital rather than the nearest closest facility. Equipment sizes like airway, masks, immobilization gear, and medications have to be adapted to the pediatric patient size. So just making sure that we're aware and familiar with these types of resources is extremely important to help these pediatric traumatic injury patients calls go better. So yeah, basically, it's so important not to think about these kids as little adults just because their bodies are working differently, they fail differently, and they respond differently to this treatment. And EMS, like you have your pediatric protocols, so we need to rely heavily on those, brushing up on our pediatric knowledge, our gear, and running through some simulations when we get downtime helps us better equip ourselves for information and education, as well as using our tools and resources to accommodate for these pediatric patients. So the first thing that we have to remember in our primary assessment is our pediatric assessment triangle. So the pediatric assessment triangle is just a rapid assessment tool used in EMS and even in the hospital setting to evaluate the psychological status of a pediatric patient based on three key components. So you have appearance, work of breathing, and circulation. So appearance would include the child's overall demeanor and responsiveness, It includes evaluating muscle tone, level of consciousness, interaction with caregivers. And then we can also remember the acronym TICLS: tone, interactivity, consolability, looker gaze, and speech. So this is our across the room assessment. So as soon as we walk in or we get on scene, what does the appearance of this child look like? Abnormal findings can pretty much indicate altered mental status or a possible airway obstruction. Work of breathing, we have to remember, it focuses on the child's respiratory effort. Signs of increased work of breathing include nasal flaring, retractions, grunting, abnormal respiratory rates that may be tachypnic, but it could also be a slower respiratory rate. Just remembering your normal vital signs for the age of the patient that you're responding to is really important for assistance in these work of breathing and understanding respiratory rates. Circulation, so perfusion status. We are looking at checking skin color, temperature, and cap refill. And abnormal findings such as pallor, cyanosis, or delayed cap refill can indicate shock or any other circulatory issues. So I really like this photo, and it kind of helps us go into understanding if one system is in a is not stable, where we are looking at. So if all three, appearance, work of breathing, and circulation, are stable, our patient is overall stable. If we have a change to work of breathing, we are in respiratory distress. If we have a change to appearance and work of breathing, we're on our way to respiratory failure. Shock could either be a change to circulation or a change to appearance and circulation. Just a change to appearance could mean some metabolic or CNS changes. And then if we have a change to all three sides, we are working toward cardiopulmonary failure. So just a quick overview, the primary reason that we use the PAT, it allows us to get that general quick impression of a child's condition, which could be crucial in emergency situations where time is of the essence. So if you're walking in and you're seeing this kid who is tripoding, they're blue, they are, their appearance is very lethargic, that's when we need to intervene quickly, and use of this pediatric assessment triangle is important. This pediatric assessment triangle also helps us guide our treatment by identifying the severity and type of physiological problems. So again, the changes to each side of this triangle lead to different changes within the body. This pediatric assessment triangle tends to provide a consistent framework for healthcare providers, and it provides positive patient outcomes. I'm sure that you guys have seen this before. It's widely taught in pediatric life support courses or your PALS courses, and it's used in various healthcare positions such as nurses, doctors, and within you guys within EMS. It's applicable both in the pre-hospital and hospital settings, making it a versatile tool for pediatric emergency care. So after we form our generalized initial assessment, we go into more of our pediatric rapid trauma assessment. And this essentially, it's a quality and sound primary and secondary assessment, which provide crucial information when treating a pediatric trauma patient because life-threatening injuries are promptly identified and managed, while also allowing for a thorough evaluation of less obvious injuries. So we start with our scene size up, making sure that our PPE is on, scene is safe. This can also be an estimated age, weight, and size of the patient. And at this time, we're thinking, okay, is this a patient that needs to go to children's, the nearest closest facility, things like that, which has specialized care for these patients? That would be where my mind would be going to. So primary assessment focuses on identifying and addressing immediate life threats, such as airway obstructions, breathing difficulties, circulatory problems, or severe hemorrhaging. So remembering our CABCs, any extenuating bleeding, and then airway, breathing, circulation from there. In pediatric patients, compensatory mechanisms can sometimes mask the severity of the actual injury. So having your systemic approach is essential to prevent your rapid deterioration of your patients. And again, like I said, having a good solid foundation of your rapid trauma assessment provides prompt intervention during this phase, which is extremely critical as children are more susceptible to sudden declines in their psychological status. And then again, frequent reassessment is also crucial in this age. After a traumatic event, a pediatric patient can deteriorate rapidly. So it's really important to remember those, that we're continually reassessing, continually looking, continually assessing our monitor, keeping a really close eye on these pediatric patients. Secondary assessment is where you're going to look for your more detailed head-to-toe evaluation. This is where you're looking for any and all secondary injuries, which may or may not be life-threatening, but could have long-term consequences if they are left untreated. This assessment includes a thorough history, so again, utilizing our patients and families on scene, and getting a good physical examination, obtaining pertinent past medical history. So like if we're on scene of a trauma patient, but this kid also has some type of cardiac or respiratory issue, then it's important to get that information because that might skew or change the way that we're looking at assessing and managing these pediatric trauma patients. This step is so important because of, again, remember their unique anatomy, their physiology. It can result in atypical injury patterns that might be missed if we don't have a thorough evaluation. So making sure that we have a good primary and secondary assessment ensures pediatric trauma patients receive timely and appropriate care, as well as improve their chances of recovery and reducing the risks of possible complications. So the very first thing that we're going to discuss is head trauma. And head trauma is actually the leading cause of mortality and long-term disability in pediatric patients. It actually accounts for a significant proportion of pediatric trauma-related deaths, with TBIs actually being the primary cause in approximately 50 to 60% of fatal injuries in kids. Falls, again, are the most common mechanism of injuries for children sustaining major head trauma, followed by MVCs, and then pedestrian and bicycle accidents, projectiles, assaults, and then sports-related injuries, with abuse being our least amount. These mechanisms of injury cause isolated head trauma in the majority of these patients. But again, remember, kids are more prone to these head injuries because they have proportionately larger heads. Their center of gravity is different. One thing that we didn't touch on earlier was they have less developed neck musculature. So their neck muscles are not fully developed, which makes it hard for them to stabilize their head during sudden movements or impacts, such as an MVC or a coup contra coup injury of them rear-ending or getting hit. And then again, they have soft skull bones, especially in these neonates and infants where their soft spot hasn't closed. The skull is more pliable, which in these patients, their head are bigger than their body proportionately. So the head is going to take the majority of that impact. So we have to remember that we could have epidurals, subdurals, and potentially TBIs from NVCs or things like this because their heads are significantly larger than the rest of their body. So just understanding anatomy and physiology of pediatric patients kind of helps us get a better understanding of how their bodies are going to compensate or decompensate in these type of situations. And then, so we have our idea of what our head injury is. So let's talk about a head injury assessment. So performing a head injury assessment in pediatric trauma patients involves, again, a systemic approach. Systemic never fails, okay? So if we have our tried and true 1 through 5 way that we are going to assess these pediatric patients and patients in general, it's hard to deviate from those when you have your systemic approach. So having this systemic approach allows us to identify the severity of the injury and then guide our treatment from there. So for head trauma, we rely heavily on GCS. Depending on the child's age, you should either use a GCS or an AVPU. So the GCS is which is modified for pediatrics, can be used to quantify neurological status with changes over time, as opposed to AVPU, which is your alert, if they're alert to verbal, if they're alert to pain, or if they're totally unresponsive. And remember, this is to assess our level of consciousness. which most docs, whenever you're calling in to give a report, should ask what their GCS is. So having a good understanding of your Glasgow Coma Scale and your numbers and noticing deteriorations early can help us avoid further deterioration for these pediatric patients. We also want to look at pupil size and reactivity. So we're looking for PERLA, equal size, reactivity to light. Are they symmetrical? Are they unequal? Are they unreactive? Both of those can indicate increased intracranial pressure or potentially a head bleed. And then we're moving on to our head and neck injury or our head and neck examination. So we're going to expect the head, face, and neck for DCAP BTLS, lacerations, contusions, swelling. We're going to palpate the skull with our hands to notice any depressions or fractures. Do we notice any boggy spots, any step-offs? Do we notice any asymmetry in the face? Do we notice any bruising, specifically around the eyes or behind the ears? We're looking at our vital signs, right? This can indicate basal or skull fractures. We're going to check for fluid leaking out of the ears or nose, which can also indicate skull fractures with a CSF leakage. So all of those things together are extremely important to help us identify something that could potentially be a major problem within transport. Then we move on to like our neuro exam. We're going to assess for good PMS in all extremities, look for signs of posturing, check cranial nerve function or abnormalities within cranial nerve function. So again, the facial symmetry, abnormal eye movements. If these patients aren't able to move any of their extremities, then we're dealing with a much bigger problem. And then gathering your information from maybe bystanders, if it's an MVC, if it's a bicycle accident or a scooter accident, there are likely going to be other people out on the street, especially if it's a nice day. So gathering as much information as you can from bystanders is important. That helps you determine, obviously, the mechanism of injury. It can provide critical clues to the potential of the severity of the head trauma. And then if it's a fall, we're asking, what is our height of the fall, whether that be like down a flight of stairs, off of playground equipment. Just an estimate of the fall height also can change our outlook if it's a fall from a standing height versus a fall down a flight of stairs. Details such as use of helmets. If it's a peds versus car, how fast was the car going? Or what is our speed limit in the area? Do we think that we were going faster or slower? Again, using all of our resources to get this information from bystanders is important. Yeah, so just remember, and even if there's nobody there, use context clues. So if you're on a street, let's say it is a peds versus car or, a bicycle accident or whatever, we're not going to be able to know how fast this car was going. But if we see a sign, hey, it's 35, we can probably give a good estimate that the car was going 35 to 45, depending on where we are or the location that we are in. So management of head injuries in pediatric patients. Again, you're going to hear me talk about systemic and standardized structured approaches for these patients because, again, it is a low call volume that we receive. So making sure that we have our systemic and structured approach is extremely important. So it also requires very cautious approaches, again, due to anatomical and physiological characteristics of kids. Start with our primary assessment, moving into stabilization, making sure that the airway is patent while protecting C-spine. In the case of altered mental status, we could potentially consider intubation by securing the airway and preventing aspiration. We're going to assess our respiratory effort, provide oxygen to maintain adequate oxygenation, so greater than 94%. Most of our trauma patients, you're likely going to put them on 15 liters non-rebreather anyway, so there is supporting our oxygenation. Ventilatory support that may be needed if there are signs of respiratory failure or hypoventilation. So making sure that we are familiarizing ourselves with common pediatric tube sizes, different blade sizes on our Mac or our mill, if that's what you're using, and making sure that we're using a pediatric BVM, or being very, very cautious of the amount of breath that we are giving whenever we are bagging a patient. Um, Establishing IO or IV access. If it's a traumatic arrest, access is access. So we need access at some point. IO is totally acceptable. IO can also be acceptable if you are failing at your attempts of IV access. Again, at this point, we just need access to get our medications. So get what you can get. Um, Administering isotonic fluids may help to maintain perfusion. But what I do want to tell you is if you have a pediatric trauma patient, they're hypotensive, they're tachycardic, they're tachypnic, they're not going to need fluids, they're going to need blood. So it's extremely important to remember that, especially if it's an MVC with obvious seatbelt signs. This patient is likely going to need blood. So getting them to a higher level of care, unless you guys have blood on board, would be important. Remembering that we don't want to fluid overload these kiddos, especially in kids with suspected ICP. So that's when it comes into monitoring our vital signs, um, being very aware of our heart rate, blood pressure, and cap refill time. So that's where it comes into play of performing your initial neuro exam, excuse me, and then moving on to doing frequent reassessments every 3 to 5 minutes of your neurological status in these pediatric patients. Um, Include your GCS, your pupils, AVPU, whatever you guys decide to include. So continuing to look for signs of increased ICP, which can include headaches, vomiting, altered mental status, or bradycardia with hypertension. So if you're noticing our blood pressure is increasing, but our heart rate is decreasing, elevate the bed, do what you can. These are the most common signs of increased ICP. If able, again, and not contraindicated, 30 degrees, that's going to reduce ICP and ensure the neck is in a neutral position, which helps promote the venous drainage from the head. Again, we're going to try and avoid hypoxia and hypotension by maintaining systolic blood pressures within age-appropriate ranges to ensure good cerebral perfusion pressure. So again, that's where it comes into, hey, we need to be aware of what are our common blood pressure parameters for patients in these age ranges, what are our goal maps for these patients, and it's all age-based. So we have to make ourselves familiar with those types of protocols, as well as vital signs in this age group. Avoid hypoxia, we're going to provide our supplemental oxygen, or mechanically ventilate as needed. If seizures are present, follow your local protocol, administer anticonvulsants for treatment. We can most commonly see this in patients with severe head injuries. They present with seizures. They're going to have a decreased level of mental status and then have our seizures. And then remembering to transfer to a trauma center. Cincinnati Children's, again, is the nearest closest. Um, Unless this patient needs a hospital right now, then we're going to go to the nearest closest facility in order to get them stabilized and transferred out to a pediatric facility. And then the last thing, which some of us are not the greatest at, I including myself, whenever we get a transport, making sure that we're checking a blood sugar. Just make sure that we're covering all of our bases for altered mental status. Blood sugar could be one that's sometimes overlooked. A lot of you guys are very, very good, but just in the back of your mind, making sure that we're getting a blood glucose with any patient that's an altered mental status patient. So moving from the head down to our abdomen. So abdominal trauma, it's a significant cause of pediatric morbidity and mortality. It accounts for roughly 10 to 15% of trauma-related deaths in kids. It's a second leading cause after head trauma in this population. Injuries can be blunt or penetrating, with blunt trauma actually comprising over 80% of all cases in the abdominal trauma category. The most common injury, this is also the most common injury that causes shock to pediatric patients due to our internal bleeding and our blood loss. Splenic injuries followed by liver injuries are the most common injuries in kids. So we're making sure that we are doing our trauma strip and flip, right? So if this kid in this picture on the A side had a seatbelt on, we would have absolutely no idea that this kid has any internal bleeding with the seatbelt sign because we haven't exposed them. So making sure that we're exposing our patients on our primary and secondary assessments. So following our A, B, C, D, E, airway, breathing, circulation, um, disability, and then exposure. So making sure that we're getting a good eye on these patients. Um, so blunt trauma can be MVCs, which is the leading cause of abdominal trauma. Falls, which is the most common in kids. Sports injuries. So we're coming to the end of football season, but we have to remember when our football players have on their shoulder pads, it doesn't cover, it covers to like the base of their rib cage. So if a patient gets hit and they potentially fracture a rib, now we're looking at splenic injuries, kidney injuries, liver lacerations. So have that in the back of your mind whenever you're getting called on scene for a football injury that's not a head injury. Um, Bicycle or scooter accidents, we see this a lot in younger kids when they might hit their brakes to avoid something, whether that be an animal, a car, another person, and then they hit their abdomen on the handlebars. Um, we see more commonly in kids with bicycle or scooter accidents of injuries to their small or large intestine, but we can also see splenic and liver lax as well. And then another one that we don't think about a lot are NATs or our non-accidental traumas, child abuse. These can result in severe abdominal trauma. So another thought to keep in the back of your mind if the story isn't lining up with what the parents are telling you, your mind can possibly go to a possible NAT. And then your penetrating traumas are your less common traumas. Sharp objects, firearms, animal bites are also considered penetrating traumas. So just, keeping an eye. You know, you might get called on scene for an abdominal injury, abdominal pain, something along those lines. And then when you expose them, you see an entry wound. So just keeping those types of things in the back of your mind. And then again, we always have to go back to why are kids more susceptible to these types of injuries than adults? They have larger organs, they have less protection, right? Their rib cage is more pliable. Liver, spleen, kidneys, they're proportionately larger and less protected by the rib cage. They have the thinner abdominal walls. So the lack of subcutaneous fat and musculature in kids can lead us to more severe abdominal trauma, especially in MVCs when we're wearing our seatbelt appropriately and we see the seatbelt sign. Um, let's see. Also, we have to remember from our 16 to 18-year-old age population, which depending, these can be considered adults, depending on their weight and height. But these are still pediatric patients. They partake in more high-risk behavior. Um, you know, kids, when they first get their license, they are excited to go out and drive. This leads them to be more susceptible to MVCs, more severe MVCs than, you and I who have been driving for multiple years. And then delayed compensatory response. So like these kids compensate extremely late. They're going to be better compensators than adults. And they're going to get to the point of no return if we are not, you know, on it with our assessment and our interventions and management. So abdominal trauma assessments, we want to assess the abdominal injuries in pediatric patients, again, with a systemic approach. So you have your initial assessment, which is your primary survey. Again, we're going to follow our addressing the life threats, identify any signs of shock, tachycardia, delayed cap refill, hypotension in the late stages. And then for kids, we want to remember that we want to do least invasive to most invasive. So the last thing that we should be doing is palpating and percussing on these kiddos' abdomens. We want to gain their trust when we're doing our assessments. So starting off with inspection, what can you see with your eyes? We're looking for any bruising, abrasion, seatbelt signs, abdominal distension, asymmetry, visible penetrating injuries. And then we want to go for auscultation if you want to follow that. I'm not really listening. We're supposed to be listening for bowel sounds, right? But at this point, that's not the most important thing to do for our abdominal trauma assessment. If this kiddo has an obvious seatbelt sign, we want to feel on this kiddo's belly. Is it distended? Do we feel any asymmetry? So listening, while it is important, isn't the most important in our abdominal trauma assessment. So the last thing that you should be doing is palpation. So you're gently pressing, and you're going to follow. I like to follow a systemic approach, making sure it's the same thing every single time, starting in right upper quadrant, left upper quadrant, left lower, right lower. And that's kind of just following the bowel pattern from your large and small intestines and your rectum. And then you're going to percuss. Any free air in the abdomen can give you an indication that this may be a bowel perf. And so that's your tympany. So that's your like high pitched sound. And any dullness can indicate fluid such as blood in your abdominal cavity. A couple of other things that we have to remember, specific injury signs. So you have your Collins sign, which is your periumbilical discoloration, which can show us signs of retroperitoneal hemorrhage, as well as your Gray-Turner sign, which that is your flank discoloration. So when you're going down your head to toe and you're exposing them, you're looking at your belly, you're also putting your hands around the back, you're going to feel and you're going to look. If you have anything in the flank, that could indicate, again, retroperitoneal hemorrhage as it's sinking to the bottom. History is super important, so making sure that we're getting a good history with these patients. Again, height of fall, velocity of impact, use of seatbelt restraints and MVCs, things like that. During your secondary assessment, any subtle signs, so hemorrhagic shock, so again, tachycardia, narrowed pulse pressure, prolonged cap refill, pallor, decreased urine output, altered mental status. These are all important things for us to keep an eye on and continually reassess in these patients. Significant intra-abdominal hemorrhage in kids can be masked by their ability, again, to maintain their systolic blood pressure. So even with our large blood loss volumes, these kids are still going to compensate. They're still going to have a good blood pressure until they don't. That's what, again, where it comes into making sure that our continual primary and secondary reassessments are important. That way we're keeping a close eye on all of our pulses, our respiratory rate, our SpO2, our respiratory rate, all of those things are extremely important, especially in pediatric patients. Let's see. Again, age kind of plays a factor as well. A lot of kids who are, I would even go to say 5 and under, are difficult to ask questions about pain. They can tell you that something hurts, but it's difficult for them to localize the pain. So, that's when it comes to our assessments, using our assessment tools, using our eyes. The kid is in pain, but we need to figure out where. So, and it's also extremely difficult. The kid might be just afraid of us. So just making sure that we are covering all of our bases, getting a good history, getting our good assessment helps us with these abdominal and trauma patients in general. Abdominal trauma management, looks like my picture didn't show up. So basically, when we're managing these pediatric patients, prompt recognition, stabilization, as well as targeted interventions can lead to a quick intervention for us to potentially not get to a life-threatening complication. So again, airway, making sure that our oxygen, SpO2 greater than 94%, we're addressing our respiratory distress, circulation, IV, IO, fluid resuscitation if it's indicated. But again, a lot of these kiddos who are showing seatbelt signs, they are not needing fluids, they are needing blood. They are needing a higher level of care than what we in the field can provide. So we need to get them to a higher level of care where we can get blood products on board as opposed to having a fluid. I've always been told that if we are using fluid for a patient who has significant blood loss, we are doing nothing but making the blood pink. So just a reminder to think about that in that aspect. Again, neurological status, we are doing our GCS, our continuous reassessment of mental status, and then rapid transport to an appropriate facility. Moving on to burns, I feel like this isn't something that we see a lot of, but it is good to focus on. It is important to remember that burn injuries are actually a significant cause of pediatric trauma. Again, not very frequently seen. It roughly accounts for 10% of all injury-related deaths in kiddos. Burns are actually the third leading cause of unintentional injuries related to pediatric mortality, with kids 5 and under being the highest risk. They actually represent over 50% of pediatric burn cases. So when we're thinking about burns, scalding burns, these can be from hot liquids such as water, soups, or coffee. At Children's, we see a lot of kiddos who, they're getting into the age of reaching up on the counter, pulling down a pot of boiling water, maybe climbing up on a chair, getting into the microwave and pulling down a hot bowl of soup. But, it's also important to remember that these scalding burns can also be in circular patterns, which can show us that this could potentially be an NAT or that non-accidental trauma that I was talking about earlier. Again, with NATs, if the story doesn't line up with what they're saying, do some more investigating, especially if these burns look like cigarette burns or if these burns are circumferential, things for us to keep in mind. Contact burns, hot surfaces, again, parents will take off their whatever they're cooking and kids will put their hand right on the stove. And you see this a lot on palms of hands, on fingers, especially of the smaller kiddos who are just big enough to like reach up on top of the stove and put their hand on that hot surface. This can also happen with irons if parents are like ironing clothes or heating appliances. Again, with heating appliances, we have to remember sometimes this isn't accidental. We get into our non-accidental trauma patients of they have these contact burn marks on the backs of their backs, on their bellies, on their legs, just things to remember, okay? Flames, open flames, fires, misuse of flammable substances, electrical burns, live wires, kids putting their fingers in electrical outlets, or, we get into the older kids who want to experiment to see if they can put a fork in an outlet, silly things like that, that we also have to remember. And then one less common is lightning strikes. Always remembering that lightning strikes are a possibility with burns. And then chemical burns, chemical agents, household cleaning items, or industrial chemicals, which these we're probably going to see more of like bleach burns, of kids pouring bleach on themselves, ingestions, right? We see kids who ingest bleach a lot. Just being aware of the different burn styles. So your burn assessments, burn injury. So on this page, we want to evaluate the severity, the extent, potential complications, focusing on early recognition and stabilization for burn kiddos. Again, focusing on our initial ABCDE primary assessments. Burn patients, specifically, let's use house fire as an example. If a patient appears fine, but they have soot around their nose or their mouth, that could potentially lead us to thinking of a possible airway complication and lead us into potentially intubating this patient or taking this patient's airway for airway management. Assessing the burn severity, so we're looking at burn depth and total body surface area. So first degree, just as a reminder, red, painful, and dry. Partial thickness, which is our second degree, red, blistered. We're still very painful in this state. And then we move on to our third degree, full thickness burns. So these appear white, leathery, charred, and little to no pain because our pain receptors have been burned off at this point. And then using the rule of nines. So again, this picture actually had the picture of the rule of nines and how it differs in pediatric patients of age categories. So just remember, rule of nines modified for kids. We can't use the same style of rule of nines as we do for adults. So just being familiar with the changes in pediatric patients. And then for smaller burns, we can use the patient's palm and calculate based on their palm as well, if you don't remember the rule of nines. The patient's palm estimates roughly 1% total surface or total body surface area. If you get in a pinch and you're like, oh my goodness, I need to estimate this really quick, use the patient's palm. figure it out with 1% and go from there. Making sure that we're identifying associated trauma or complications. So again, circumferential burns assess for impaired circulation. Risk of a compartment syndrome is extremely high, specifically on extremities, legs, arms, things like that. Inhalation injuries, like I was saying, in house fires, you're monitoring for hoarseness, respiratory distress, wheezing, even that like brown soot around the nose, the mouth, being very aware of those things. Let's see. Electrical burns, entry and exit wounds, assess for hidden internal injuries, just being aware specifically with electrical outlets and with lightning strikes. Again, history is so important. We want to determine the cause. So we're asking the patient or the family, hey, how did this happen? What do you remember? This isn't a judgmental conversation. It's just, hey, reassuring the family, I really need to help you. I really need to figure out where we are and why we're here. Can you just give me a little information? Were you cooking? Was this kiddo standing on a chair? Like, did they pull down something? Did they touch the top of the stove? Whatever it may be, non-judgmental, asking those questions to help provide assessment and management for these patients. And then again, like I said earlier, we're assessing for potential child abuse, particularly with unusual burn patterns or that history that doesn't line up with the injury that the family is telling you. Burn management, pain control, making sure that we're keeping these patients warm, stabilized. So due to kids' unique physiology, we're at higher risks for complications, fluid loss, hypothermia, airway compromise, all things to remember that I've been discussing through the entirety of the PowerPoint. Again, continuing with our initial assessment, airway, breathing, circulation, disability, and exposure, or ABCDE, inhalation injuries, airway compromise. We're providing high flow oxygen via a non-rebreather, especially in those cases of smoke inhalation or carbon monoxide. Monitor for respiratory distress or hypoxia, IVIO access, and for fluid resuscitation, in burns covering more than 10% of that total body surface area, we want to initiate that fluid resuscitation using preferably warmed isotonic fluids, normal saline, LR, per our local protocols. Again, making sure that we're assessing our GCS, our AVPU, considering potential hypoxia or carbon monoxide poisoning in the sense of a house fire. Exposure, we want to get these kiddos exposed. We want to see our percentage of our burn percentage to see how much we have, and then recovering them with a sheet or a warm blanket. Let's see. So we want to stop the burning process if we get on scene and these kiddos are actively, let's say they're on fire or whatever the case may be, remove them from the heat source, cool the burn area with clean water for no more than 5 minutes. We want to prevent hypothermia again. Remove clothing, jewelry, anything that could potentially adhere to the skin, we want to remove so that way it doesn't adhere. And then when we go to remove those clothing, we pull the skin with us. Pain management, we want to administer appropriate pain relief based on your local protocols. That could be fentanyl, morphine, whatever you guys carry. Even though these kiddos may not be able to tell us that they're in pain, our understanding of burns, we know that these burns are significantly painful. So making sure that we keep these kids warm and comfortable. And then if you get to the point where you can cover the burn, you want to apply a clean, dry, non-stick dressing or a sterile burn sheet to the affected area. You don't want to use any ointments or creams, especially in the pre-hospital setting. And then moving on to that fluid resuscitation, anything greater than 10% of what you estimate, begin your fluid resuscitation and monitor for signs of hypovolemic shock. Preferably warm fluids, but if unavailable, regular fluids are fine. And then we want to get these kiddos in the back of our ambulance and get them moved to a higher level of care, which is a pediatric burn facility. And then lastly, during resuscitation, kids with major burns may develop long-lasting hypermetabolic responses, which can increase which causes an increase in energy expenditure and protein metabolisms. This causes increases in glucagon, cortisol, things like that. So we need to just be aware of the physiological aspects of burns, and keeping a close eye on those types of things. Um, let's see. Moving on. So I know I've been kind of touching on NATs throughout this presentation. We're going to talk about them more in depth. NATs or non-accidental trauma can be related to our child abuse. And child abuse is, we don't see it often, but we do see it. It accounts for roughly 1,800 child fatalities annually, with infants and toddlers being the most vulnerable. It's estimated that 1 in 4 children experience abuse or neglect during their lifetime, and physical abuse accounts for a significant portion of severe trauma-related cases in the ER settings. So types of abuse, we have physical, that's hitting, shaking, punching, anything, burning. It can result in fractures, head trauma, etc. Neglect, so failing to meet our basic needs, nutrition, medical care, supervision. This can lead to severe injuries and or death. And then intentional injuries, so shaken baby syndrome, suffocation, inflicted abdominal injuries, stuff like that. Let's see. The majority of child abuse cases are actually perpetrated by individuals who care directly for these kids, caregivers, parents, if these kiddos are at daycare teachers, just really important to keep that in the back of your mind that this likely isn't going to be somebody who just meets this kid for the first time. It's likely somebody who is very much involved with this kid's life. And parents are actually the most common perpetrators. They account for roughly 78% of all child abuse cases, with biological parents being more frequently involved than step parents or adoptive parents. Relatives and caregivers, this can be siblings, grandparents, extended family relatives. They contribute for a much smaller proportion of cases, but still have a fairly high incident rate. And then we move on to gender and relationship trends that we see in non-accidental trauma kiddos. Contrary to popular belief, moms are actually more frequently reported as abusers in neglect, possibly due to their primary caregiving role. In male caregivers or fathers are more commonly associated with severe physical abuse, including shaken baby syndrome and head trauma. Some risk factors for the perpetrators, just keeping our mind open and thinking: substance abuse, mental health issues, economic stress, domestic violence, a history of child abuse. So if you're getting a call for of a kiddo who the older sibling may have been abused, just something to keep in mind and think about when going on these calls for younger siblings. So when assessing our pediatric patients with suspected child abuse, it's super important that we evaluate these kids with sensitivity, thoroughness, and a focus on the child's safety. A non-judgmental approach for these patients and families. Identify injuries, document your findings, and report any concerns while minimizing further harm to the child. So your on-scene assessment, you're observing the environment for unsafe conditions, lack of basic necessities, signs of neglect. So you're looking for unclean living conditions or lack of food. You're noting the demeanor of the caregivers, including hostility, inconsistency, or another one that we don't commonly think about is over-explanation of injuries. So the parent or the caregiver is consistently telling you, hey, this is how this happened, and trying to cover all their bases so that way they leave no stone unturned. History gathering, you want to obtain a detailed history of the injury, including timeline, mechanism of injury, and evaluate whether the explanation of the injury is consistent with the signs and symptoms that the patient is experiencing based on age, developmental abilities, and your injury pattern. Again, be cautious of vague, conflicting, or even evolving accounts from the caregivers. So as well as over-exaggeration, very little or minimal information, or a story that's consistently changing would be consistent with NATs. Doing your physical assessment, DCAT BTLS, head to toe, you're looking at the skin for bruises and unusual locations, including abdomen, back, buttocks, ears, which those are all common places for injury for kiddos. Skeletal, we want to think about if this parent is telling you, oh, they fell off their tricycle and this kid is 7 or 8 months old, that doesn't align with the story that the parent is telling you, but we notice bilateral femur fractures. Okay. So these injuries are inconsistent with the story that we're receiving. So that puts our senses on high alert. Neurological status, you're going to evaluate for signs of head trauma, altered mental status, seizures, any retinal hemorrhaging. So in their retinas, you can see like pooling of blood or hemorrhaging. Again, that can be intracranial bleeds, that can be head injuries from a parent, picking the patient up hypothetically by the legs and hitting them on the bed. Just something to keep in mind in the back of our mind. Again, non-judgmental aspect when assessing these patients and families. We want to make sure that we are assessing for behavioral changes in the parents or caregivers, as well as the child. So we're assessing the child's behavioral and emotional state, noticing any potential withdrawal, especially if you have a male EMS provider and this kiddo is withdrawing when they are trying to assess this patient. That shows us a lot of red flags when it comes to potential for pediatric trauma. And then as well as like observing how the caregiver and child interact, signs of tension, neglect, or lack of concern by the parent. Document all of your findings. Document, right? If you didn't document it, it didn't happen. So making sure that we are being very meticulous of locations of injuries, whatever we see in the house, interactions of caregivers with the patient, interactions of the patient with us or the caregivers with us, continually changing stories. And then again, avoid making accusations, but report any suspicions. So if something feels off, it's okay to report it. Child Protective Services are required by law to look into any reports, even if they come back negative. It could just be a weird family dynamic or, something odd going on in the house, but not abuse or neglect. Document and report anything that you find suspicious or different than what you would normally expect to see in that type of patient. So management of these kids, immediate medical care and steps to ensure the child's safety are our two biggest things. Stabilizing the patient, documenting findings, reporting anything that we find to protect this child from further abuse, ABCs, life threats, administer oxygen, again, head to toe assessments, again, document thoroughly, record all observations, any injury patterns, the emotional state of the child, and any caregiver interactions. Use clear, objective language, not subjective language. So it might make you feel a certain way, but using clear, objective words that make no assumptions in these types of injuries are extremely important. Avoid personal judgment, accusations. If you guys are able, usually this happens in the hospital setting, we photograph all of the injuries to add to the case. Whenever we are assessing what we call a children's a ROPA or a ROSA. ROPA would be rule out physical abuse. And then ROSA is rule out sexual abuse. So you might hear those terms used interchangeably. Whenever you guys are dropping off a patient, they might ask you those questions if you suspect sexual or physical abuse. Just something to be mindful of. Reminder, we are mandated reporters, so reporting to local authorities as required by law. So some things that mimic NATs. So the biggest one that I can think of, especially in our neonate and infant population, is Mongolian spots. This is a dark brown, what would appear to an untrained personnel as a bruise above the buttocks. But it is actually a genetic condition on these kiddos. So that's one that really mimics. Recently, cupping on the left-hand side has become really popular in athletes, specifically competitive athletes. So cupping is it's used in Chinese medicine. So if you pick up like a Middle Eastern or Eastern European or Chinese patient, and they have these bruises on their back, know that it is a therapy, and it is a traditional remedy in these populations. It involves heated cups placing on the skin to relieve pressure or illness. Circular bruises, they are symmetrical, and if you see something like this, know that it is not an abusive situation, but rather likely a remedy for illness or injury. Coining, which is on the right-hand side, which we don't see very often. This is primarily common in Southeast Asian cultures, and it involves rubbing a coin or a smaller object on oiled skin to treat an illness or expel what they would consider bad wind. Linear parallel lines. So this might look like this patient had been whipped. Remember, being whipped would be not a symmetrical presentation, as in this coining presentation. Also, another one is like forced hot baths. We don't really see this a whole lot. It's the use of hot warms or baths as a purification or treatment of illness. But the three that you're primarily going to see are coining, cupping, and Mongolian spots on your kiddos. So some other considerations, communicating with pediatric patients and EMS makes a total difference in their care and experience. Children process fear and pain and confusion differently than adults do. So your approach needs to blend reassurance, honesty, and sometimes creativity. So just a quick guide of how to talk and address these patients. You want to start on their level. So the very first thing that I do whenever I address pediatric patients is, let's say they're laying on the ground. I bend down, I get on their level, and I'm talking to them eye to eye. Get low, kneel, or sit. So that way you are looking at them eye to eye and you're not towering over them. Towering over them can present some fear for these kiddos. You want to use a calm and soft tone and avoid shouting, even in noisy environments. So if you're in a noisy environment, you can manage the environment as much as you can, but also remember, hey, I can get down to their level, I can look them in the eye, and I can talk to them in a normal tone, whispering in their ear, or saying things in their ear so that way they can hear me. And I am direct and I say it in a calm, soft tone. And then adjusting your language. This one is sometimes kind of hard. With adult patients, we can say, hey, I'm going to take your vitals. With kiddos, hey, I'm going to listen to how strong your heart is. I'm going to see how big your muscles are by putting a blood pressure cuff on. Use simple, concrete terms in short sentences. So with an adult, you can go on and kind of elaborate on what you're going to do. With kids, short, direct, and to the point. Smile. I mean, using this nonverbal type of just using your nonverbals, smiling, using your eyes, trying not to like ball your fists up, being relaxed, helps you to just get on their level and gain that trust and reassurance with your patient. For very young kids, you can describe sensations of procedures, blood pressures, tight hug, needle pokes. This is going to feel a quick poke, like a mosquito bite. I know we use in the hospital setting, hey, we're going to see how big your muscles are by using a blood pressure cuff. I'm going to listen to how strong your heart and lungs are. I'm going to listen to you breathe. I'm going to look in your eyes. Tell me what you can see, type of thing. Using their language for them to understand what you are going to do takes away that level of fear for these kiddos. Building trust, introduce yourself. Like I said, getting on their level. I always go in and I immediately get on their level and I say, hey, my name's Kaylee. I'm going to be the nurse taking care of you today. What is your name? If they're able to communicate with me in that term. That kind of allows them, hey, I am just a person just like they are, but I am here to help you. And if they start to get upset or frustrated or whatever emotion they may start to experience, I'm like, hey, it's okay. It's okay to be scared. I'm scared sometimes too. And being able to relate that with them helps build that trust. You can also offer offer them resources and choices when possible. So, hey, I have to put in this IV, but what arm would you prefer? Do you want it in your arm? Do you want it in your hand? In situations where these choices are allowable, it's important to give your kiddos these choices. Or do you want to hold mom's hand or mine? So, hey, I'm gonna do this little poke. Do you want to hold mom's hand? Do you want to hold one of our hands? Just having them have that autonomy of a choice in a situation where they feel is out of control and they have no choice. Distraction and play. So ask them about their favorite cartoon, their pet, or their toy. You know, coming, working in a pediatric hospital, right? We have all of these resources. But you guys, you don't have many resources. So that might include giving them your phone, putting on Bluey, putting on Paw Patrol, whatever their favorite TV show might be, giving them a stuffed animal, having them have their stuffed animal, um, giving that distraction away from a potentially life-threatening situation that may be going on, but having them be calm, you be calm. Um, you can also offer stickers, let them help if you feel it's safe, asking them, hey, can you be my little helper? I need you to hold this. Having them hold something that, is appropriate for them to hold, including the caregiver. So this is really important in peds. Children take emotional cues from their parents or caregivers. They're learning through actions. So keeping the parents close if possible, and making sure you're maintaining the calm environment with these parents and families. Speak to the parent and child together, not over the child's head to the kid. So I'm always direct to these kiddos. I'm talking to the kid, but I'm also looking at the parent. So I'm including the parent, but I'm basically talking to the child so the parent understands as well what I'm going to do, how I'm going to do it. I give them time frames, I give them choices when available. And be honest, right? A lot of kids will be like, oh, will this hurt? And some of us are reluctant to say, no, it won't hurt because we don't want them to get upset. Be gentle, never lie. If you lie, it's going to break the trust of that pediatric patient and they're not going to trust you. All right. So it's going to make any other procedure following that extremely difficult. Um, you can say things like, this will feel a little uncomfortable, but reassure them, I'll be right here with you, or mom will be here with you. Um, and then praise their bravery afterwards. You did awesome. You were so strong. I'm so proud of you. Um, those are so, so important to gain that trust and be able to perform that task and future tasks appropriately. And then tailoring it to age. So how to communicate in different age ranges. So you're infant to 1 year, you're primarily talking to the parent, right? You're using a soothing voice, you're keeping the caregiver close, avoiding overstimulation. In your toddler age, you want to explain simply and you want to demonstrate. So you can show them what you're going to use. So whenever we are putting in IVs in the hospital setting, we like to say, hey, it's going to be a small poke. And then you're going to have a little medicine straw in your arm. So using things like that to make things sound cool and comforting without scaring these kiddos. Preschool 3 to 5, you can use play and imagination, give choices, and explain the why. So, like if they have a stuffed animal, be like, "Hey, can I do it to your bear? Can I show you what it's going to be like on your bear first?" Again, in situations where time allows, in pediatric trauma patients, this really isn't going to be a way to handle your kiddos. But if you're on like a diff breather or, maybe a pediatric trauma, but they are stable, you are able to do these things. Try to incorporate them. School age 6 to 12, you're giving honest explanations, you're involving them and offering reassurance. And then your adolescents, you're just treating them with respect, offering privacy and explaining procedures clearly, and you're talking to them directly. Lastly, and I know this is really hard for us to do, is to stay calm ourselves. Children, just like all of us, can sense fear and anxiety, and the calmer and more confident that we appear, the safer they feel, even in chaos. Um, and then here are some references. And that is all that I have for you guys. Does anybody have any questions, comments, concerns? You are more than welcome to put them in the chat. I am going to stop sharing my screen and I'm going to come back. Does anybody have any questions? Okay. Well, Tony, if there are no questions, I appreciate it, and I am very, very thankful that you gave me this opportunity. And I hope that you guys were able to get a little information about pediatric trauma moving forward and can take some of this information with you in the field and in the future with your future patients.
Thank you so much, Kaylee. So we record all these, so there may be questions that come up later. They
Okay.
usually reach out to me,
Yeah.
and if it's something simple I can answer, I will. But if not, I'll send it through you and make the
Yeah. I'm more than
contact.
happy.
And everybody else, thank you for your time. And our next one will be in December, our third pediatric class, trying to cover the PALS type stuff from Chris Barber. So we will see everybody back then.
Awesome.
Thank
Thank you so
you.
much.